Hello, everyone. I'm Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk. My co-host here is JD Landon from Virginia Beach, Tidewater Physicians, or Emergency Physicians at Tidewater. There we
That's
go.
the one.
And my special guest is Zack Shinar from Sharp Memorial Hospital in San Diego, and he is leading the I would say charge on a new technology, a new idea of ED ECMO. And I have to say that Zach, I knew some of this stuff, but I didn't know the level that ED ECMO is capable of, and it's truly inspiring. And it's kind of when I talk to you about this, I see you trying to be measured and trying to be, don't oversell the capability of it and that sort of thing. And then every now and then the passion pokes out, and I can see where where you're really excited. It really gets you down deep in your gut that this is a skill that actually could change a lot of lives and has changed a lot of lives. And I appreciate your poise and trying to not oversell this, but at the same time, you can't deny that if this was a widespread skill and we had the logistics to make this happen, we would be having a huge impact on emergency healthcare in this country, no doubt. So thank you for joining me, and I'm going to turn the questioning over to JD because he's leading the charge on this from our standpoint. JD?
Awesome. Zach, thanks so much for coming back. We're super excited to have you on again. I know, but let's just jump right in. Today's podcast, we really want to jump into a little more of the details of what it actually looks like to do ECPR in your ED. What are the steps? What should we be thinking about? All these kind of questions. I know, Zach, from having gone to Reanimate, it's my other plug. Check it out. It's worth your money. It's in San Diego. It's incredible. You can have drinks with these phenomenal people. Joe Bleza, Scott Weingart, just phenomenal people to learn from. So if you're interested in really doing that, I would argue it's a must do. But one of the things we learned there is this idea of stage 1, 2, 3. It's probably the way and the framework that we're going to be working at our shop. And I would love it if you could kind of walk us through what is this idea of stage 1, 2, 3? What does it include? And how does that kind of go at Sharp Memorial?
Absolutely. Well, JD and Mark, thank you for having me. This is just phenomenal to talk with both of you. And yeah, JD, it's great having you out at Reanimate. It's so much fun. Okay, so the stages, yeah. So we tried to break it up into a couple different ways just so that you have a hard stop during the procedure. And the stage 1 is where we put in for these cardiac arrest patients who are in active CPR and we don't really know a lot about them. We might have misinformation from the medics, and we've got all kinds of diagnostic dilemmas going on right at that moment, including a million different things going on at the same time. So during stage 1, you're putting in just some placeholder lines. They're small cannulas. It's a 5 French in the femoral artery. It's a 9 French in the femoral vein. You get to be able to transduce that femoral artery and then do all the great things that you can do with that. Manage their chest compressions, decide whether they're actually in cardiac arrest or not, decide if they actually just need pressors. And so there are advantages just to having an intra-arrest arterial line. At that moment, once you put in those lines, then a decision needs to be made. A decision needs to be made whether you're going to go further with ECMO. Now, all the other things that need to go on, you have to have the cannulas ready, you have to have all the dilators ready, and have hopefully kind of prepared for this. But ultimately, a decision needs to be made at that point. In our shop, we try and allow one whole physician as their job to make the decision on whether you go on ECMO or not. Because it's not easy. You're having to incorporate information from the medics, information that you see in the patient, maybe even do a quick chart review if you can, and say, what actually happened here? Are they a candidate for ECPR? And so that point between stage 1 and stage 2 is important. If the physician decides, yes, we're going to proceed, now you're going from actually having these small cannulas into having garden hoses into the groin. So these are large cannulas. This is a 17 French arterial, sometimes 15 French if it's a smaller woman, and a 21 to 23 French cannula into the femoral vein. So these are large things. And so how you do this is that you chain over that cannula that you have in, you put in a longer wire. We typically use a stiffer wire additionally to start dilating up. You become very quickly a snob about a couple of things. One thing I'm a snob about is my needle. I like my needle for when I'm trying to insert into the femoral vein and femoral artery. But the second thing you get snobby about is these wires. And so these Amplat super stiffs are pretty cool. They've got a floppy tip and they're pretty hard, so you can really rail the dilators along them. But they have some downsides, and that is that they are hard and that they can puncture through a vessel. And so you have to be very cautious about that, the use of these dilators or these wires. So the process of dilation is similar to what you would do for some of your dialysis catheters. You put in a wire, you go up with a smaller dilator, which might be, let's say, 12 French, and then go up to 16 French on the femoral artery. You might go from 15 French up to maybe a 19 French on the femoral vein. And then you insert these large cannulas. There's a couple of little technical things you got to do as you're inserting those cannulas, but that sort of gets you to the end of stage 2. Setting up stage 3 is the actual initiation of the pump. So we go from having cannulas in to turning on the pump. And this is where a whole bunch of things need to occur. And it's good to have an accessory brain next to you, a piece of paper or something that'll checklist, that'll say, did I do every single one of these things? And so that is stage 3. So connecting the cannulas to the pump circuit, making sure there are no air bubbles in there, because air on the venous side is a small problem. It will go through the oxygenator and hopefully get caught. But air on the arterial side is a huge problem. That is directly sent into the patient, and that is going to be an air embolus somewhere in that body. You have to make sure you have no air in that circuit. You then take off clamps, you increase the speed of the motor of the actual ECMO machine, and you now pull blood out of the venous side, push it through a oxygenator where you can take off CO2 and improve oxygenation, provide some perfusion, and push it retrograde up the femoral artery. And those are the 3 stages.
You mentioned before we were talking about this, you were talking about pushing blood against the cardiac vasculature. Is there any advantage to going up higher? First off, how far up are these cannulas going from the femoral artery? Are you getting up into the lower aorta? What's the length that you're attempting to do this at?
Great question. So the femoral vein cannula is long. It goes up typically at the RA IVC junction, or if you are a cardiologist and you have fluoro, you can put that cannula all the way up into the SVC RA junction. The arterial cannula is not long. It is short. It will go probably just below the bifurcation into the iliac arteries. And so you will get perfusion down that opposite leg, and you will get perfusion up the aorta. But you do have a problem in the ipsilateral artery. So that blood is actually going to have a problem getting down to that lower extremity. Sometimes you're fine, but that sometimes is not enough. So on 100% of our patients, we put in a distal perfusion catheter, which is a catheter that is a side port off the arterial catheter to provide perfusion to that leg that has the arterial cannula in it.
Now, obviously, you would put a huge garden hose into the carotid, but is there any thought of doing a side cannulation much higher?
When we first started doing this, I had several CT surgeon friends that like, why are you guys mucking around down in the groin? Just put it right into the aorta. Do a lateral thoracotomy and put it right into the aorta. And I have not adopted that yet. It has been tempting, but I have not adopted that yet. You do get away from some of the physiologic problems. You mentioned things that get me excited. One of the things that gets me very excited, I mean, outside of all the amazing patients that you actually saved. But the physiology of ECMO is so fascinating when you start looking at what happens at that proximal aorta.
Okay, so we've gotten the cannulas into the femoral artery, femoral vein, got them placed. The pump is on. The perfusion is happening. You were talking about step 1, 2, 3. Is there a third step here?
So the third step is the initiation, when you connect the cannulas and you turn the machine on, and now you have, if you've done all your checklists, then you hopefully have at least some flow to the patient, which this is where this physiologic stuff becomes very interesting. So you have flow to the patient, but you need to start very quickly deciding whether you have perfusion. But once you've started the machine, you've now completed stage 3.
So you actually stop CPR.
You can stop CPR, but you have to understand that you have not necessarily restored perfusion to the patient. So I know that sounds confusing, but just because you have 5 liters of blood going through the ECMO circuit back into the patient, that doesn't mean that you have an adequate map on that patient.
Sure.
And you're not going to be able to tell, you're not going to be able to get a peripheral blood pressure on that patient. So very quickly, after you've done the 3 stages, you need to do a couple other things. One of them is put in a right radial art line.
Okay. And what do you expect when you get that right radial art line?
You're going to get a couple things from that. One is you're going to get a blood pressure, a map.
And what do you expect
but the
there?
second,
what kinds of numbers are you expecting there?
it can be quite variable. In fact, the immediate moments after you get restoration of ROSC with these patients, I mean, they might still be in VF and they might have nothing yet, but fairly often, right after you get ROSC, they have phenomenal blood pressures.
Okay.
Then you get the circulation of all the apoptotic cytokines, all the badness that's been circulating in this patient for the last hour as you did chest compressions, and their EF quite frequently then goes into this hibernation or something to that effect for 4 or 5 days. So you kind of have to be ready for some additional help from a pressor standpoint or from a blood standpoint to try and increase their blood pressure.
Okay.
So I want to jump here and go take us back to stage 1. So stage 1, we're just focusing on getting a central venous line in, femoral art line in. Tell us all how you lay out the choreography of your room. Who's where? How many docs do you have in the room? Do you need residents? Do you need extra people? Who runs the code? How do you guys run it?
So again, every place is going to be different. Different teaching hospitals are going to want to have this set up differently. Different people have different human resources. At our shop, we are physician poor. We have a couple docs on, and that's it. So we typically run our ECMO resuscitations with 2 docs. One is the doc that is main goal is to be cognitively available, that they are there to do the intubation. We usually allow, it's kind of what their main job at the very initiation, at very beginning, and then to go and figure out everything that happened to the patient. Are they an ECMO patient? That second doc's job is to get in the cannulas. And so that's their sole job. They are not involved in the inclusion criteria as much as oftentimes when I'm doing the cannulas, like they'll be asking me, is this patient an ECMO candidate? And I'll say, talk to the other doc. Like, that's not my job. And so you really have to get a binary, bifurcate, get away, have your total energy on the cannulation or have your total energy on the inclusion criteria. And so we try and do that as best as possible. There are a couple other components here which we think are critical. One is our nurse-led code. So we have one nurse whose job is to run the code so that those 2 docs can do what they're supposed to do and have their tasks managed well. So that nurse's job is to make sure that we do pulse checks, that we maintain optimal chest compression depth and timing, and when we get our art line in to manage that. They're responsible for epinephrine administration. If we want to give it, we kind of minimize the amount of epinephrine that we give in our department. And then just all the ACLS stuff, that is their job. The final person, and this was a game changer for us, a total game changer. And this is one of these things that I think the podcast does so well. Reanimate is fantastic at this because the conference pulls faculty from all over the world, and then we really get to talk to them and see, how do you do this? How functionally, what do you do? Step 1, step 2, step 3. Even at R8 that JD was at, I was talking with Jason, and my cannulation technique, I got a couple pearls from him, which I'm now implementing, which I think are very useful. But
were you going to say wire assistant?
And so, yeah, so the key person here is wire assistant.
Yes.
Thank you, JD. Yeah, so we took this we just ripped this from Minneapolis. We said how their paper, they had this 6-minute cannulation time. We don't have 6-minute cannulation times. How is that even humanly possible? Dimitri sends us a video, and sure enough, it's 4 minutes and 59 seconds cannulation time. And we said it's impossible. And we said, well, what do they do different? Well, they have somebody in the cath lab who every day hands people wires, and they know what to do next, and they know the next step. So we adopted it. And sure enough, with our techs or our nurses who have not even close to the amount of training that these cath lab techs have, they have provided us with such a great improvement in our cannulation times. They allow us to have that needle in, and then without turning your head, like we're talking about minutia, we have to focus on so much minutia. But when you've got that chest compression going on, you're trying to get the femoral artery cannulated, you put your needle in, instead of turning your body, changing your hands, all the things that get that needle outside of the vessel, you simply have a wire assistant that hands you the wire, and you stick it right in, and now you're off to the races. And our cannulation times have gone from, I mean, they were just enormous at the beginning, but now we are right around the 6-minute mark.
It's incredible. I mean, it really is. It's inspiring though. It's inspiring to know that it's not only, an interventional cardiologist that can pull this off. I mean, that's incredible. Who do you have doing, who is in your ER the wire assistant? Are these nurses? Who's doing the job?
Yeah, nurses and techs and people that have been trained. The great thing that we have is that we have this conference, and we put it on all the time, and so they get to go and actually teach at these conferences and learn and see and do all the things that we do. So I should not just talk like these are people that are not trained. They get to see this a lot. And when an ECPR patient comes in, we pick out the very best one of them in the department, and we pull them over, and they become wire assistant. So so it does take some skill set, but again, it's not massive skill set. This is the ability to hand you the right wire, and then do the cannulation dilators at the right steps.
Are they handing you even the wire for your initial cordis or whatever you're using, trialysis catheter? Are they even handing you that wire?
That's the most important wire, right? That is the wire. We separate things out into stages 1, 2, and 3, but if you are for sure going to an ECPR patient, then you can go straight to that Amplatz wire right from the needle. Okay. And that's what Minneapolis does. A lot of facilities do that. We put that separate step in there just so that you know that on a good percentage of these patients, you might not be ready to make that decision right at that time.
Okay. And then so other than physically just handing you the wire, what's their role? What are they actually physically doing? For people who have never kind of gotten their hands on this, you put the needle in, everybody knows how to post central line, and we understand what to do with wires, but what's that wire assistant specifically helping you out with?
They're helping you so that you don't move your hands, so that you don't pull the needle out of the vessel, and so that you're in the optimal place so that wire can just go straight into the vessel. So, our wires, they all come in these circles, right? They're I'm forgetting the word, but they're packaged. And so you got to get it out of that package. That package is detrimental to you putting the wire in the vessel. So pull it out, the first thing that I do is I just put a huge drape over their legs. Optimally, there's ones that have 2 femoral holes so that you have both sides available to you. And then you go all the way down the legs. Actually, we have a special ECMO cart at the end that just gives us even more room. And so those wires can run all the way down there. You have a big sterile field, and you can take them out of that casing and have it available just to stick directly into the vessel. And then you've got it. Then you've got your vessels. Your vessels are done, and the rest of it is just procedural.
I have a question here, and that is that, do you have one hand with a needle and one hand with the ultrasound probe, or do you have somebody else managing the ultrasound probe?
Great question. So I manage the ultrasound in my left hand, the needle in my right hand. I'm on the patient's right side. And when I get the needle into the vessel,
That's right.
and this is actually the change that Jason was teaching me. I used to think that I should take my left hand, put the ultrasound down, grab the wire, and put it in with my left hand. And it might be the best thing, but I think actually I agree with Jason now, is that the optimal thing, and we're talking about minutia here. Sorry, you guys wanted the minutia. Here it is.
I love it. I love it.
Is to put that ultrasound down with our left hand, take my left hand, grab the needle, and then use my right hand to put the wire in.
Would you not trust the tech to put the wire in?
No, I put the wire in. Yeah,
Okay.
I put the wire in.
Okay.
And also, I mean, this is also, which wasn't mentioned, but I guess you can kind of think about it, is that I don't use the syringe, right?
Okay.
Cardiologists don't use syringes on the back of their, I mean, sometimes they do, but to just have that syringe, that's a whole nother step that can get you out of the wire, out of the vessel. So allowing your needle to be there in your hand, you can see the pulsatility if they're not in cardiac arrest. If they're in cardiac arrest, you will be fooled. And this, one of the most important things here is to make sure that you're actually in the vessel, that you didn't go through the artery and into the vein and then cannulated at what you thought was the artery is actually the vein. And that, I think, is a worthwhile place to pause and say a slightly tangential thing is that every mistake that you could possibly make, I've made. And so I am so anal about these things that because every little detail is so important to the success of this, that you just have to be so anal about little teeny things. So watching that needle go in, watching the wire go in, confirming where your wires are, and then proceeding on.
How are you guys confirming your wire placement?
So confirmation of wires can be done a number of different ways. The ideal way is with fluoro. I'd love to have fluoro.
We'll just pull that out. Just pull that out of the corner in the ER. Just roll it over.
Yeah, but we say that, but I'm telling you that I believe that we're going to have fluoro in our ER, in our ERs. There are ERs that have it. There are great. I mean, the Japanese hybrid ER is just phenomenal. I mean, Minneapolis built a fluoro in a truck that they're driving around Minneapolis right now. So this is not rocket science. We can get fluoro, but that's the ideal thing to use. A poor way to do that is actually just put a chest X-ray film behind the patient, shoot it, and there's your fluoro. You can see the wires right there on that chest X-ray. If you have a portable system, you can just look at the screen.
And you're putting in the venous catheter first and the arterial catheter second. Does it matter?
We're not even talking about the cannulas here, Mark. We're talking about the wires.
Well,
you want to make sure the wires are in the right vessel, because putting someone on AA ECMO, not very useful.
No, what I'm saying is that the wire, but what I'm saying is does it matter the sequence of putting wire first in the venous side, then the arterial side? Does it matter?
There are people that have strong opinions on this. I do not have a strong opinion. I always go for artery first because it is the hardest thing. The artery in cardiac arrest is very small. The vein is massive. And so getting it in the artery is job one. And then after that, I can get it in the vein.
Got it.
What about ultrasound for confirmation? Are you guys using ultrasound at all for confirmation?
So TEE, we do have TEE. That is a way to do it. It's a little bit logistically challenging. And then, of course, just your regular ultrasound, you can put it on there. And if you can see the vessels, you can see the wires distinctly in the proper vessels, then that is a good way to check as well.
And are you checking at the groin, or are you checking subxiphoid?
So both. So the
Okay.
TEE sub could get you the great view of the IVC and seeing that your wire is there. And you can also see an aortic view. The transthoracic view is sometimes problematic because of the air for trying to get that arterial, that aortic view.
Yeah. Okay. Did you have a question, Mark?
I think that we're getting toward the end of our time period here, and I just want to make sure that we talk a little bit about the politics of getting this thing going. I think that techniques are great if you can't sell the hospital on it. How did you go about? I understand you had a perfect setup, but what if you don't have the perfect setup? What are the political logistics of getting a program like this going? And we're
So
going to talk
yeah,
a little bit about, and I want you to address money.
yeah. I mean, money is I don't avoid the money topic because I think it's so important. Money in making this a viable option for your hospital is important. I think there are a lot of misconceptions when it comes to money, and particularly in hospital stays associated with these patients. So the mantra would be that you're going to be in the hospital for eons and you're going to take up all the ICU beds, and we can't do this. Our experience has not been that way. We have if you get in, if the vast majority of our patients actually don't survive even one day, the ones that die. So it's a cardiac death. So from neuroprognostic standpoint, you can't decide whether someone is cognitively dead for several days, unless there's something terrible on the CT scan of the head. So you need to take time with neuroprognostication, but with a cardiac death, we have pronounced quite a few people, even in our ER. So in general, these patients don't have long hospital stays like the VV patients. So one of the bad things about COVID was that it gave ECMO a bad rap in that regard. These patients were on ECMO for months and months and months, and only had a very small improvement in survival from the use of the machine. That's not the case with ECPR. These are 5-day runs with 10-day hospitalizations, and they walk out oftentimes neurologically. Most of the patients are also neurologically intact, which is a key part of this. So when you're coming to your hospital and you hear things like they're going to take up all of our ICU beds, that just really isn't the experience we've had so far. Are you going to have tough decisions sometimes? Yes. These are the same tough decisions you have with cardiac arrest that aren't on ECMO. What do you do when family members don't want to take them off the vent? These sort of decisions, they will occur. From an economic standpoint, in the US, ECMO in general is advantageous to most hospitals from an economic standpoint. It is and like I said, the idea of how you utilize this, and I think the Netherlands did this quite well. They said, okay, here are our capabilities as a country to provide cardiac arrest care. How do we do this in a way that allows for us to use ECMO equitably throughout the whole country? And they said, okay, well, if that's the case, we've got to have an inclusion criteria that's this tight. And that's why their age is so low. In your hospital, you're probably going to make something similar to that. And probably if you're starting your program, you should start relatively tight on your inclusion criteria, meaning VF, VT, witness, bystander CPR, and cannulation times less than 60 minutes. If you're some of these other programs which have already shown these successes, I have calls quite frequently about places wanting to expand their inclusion criteria because they're saying, we know there are more survivors that we could get with these. We know that if we just broadened it to PEA, if we broadened it to certain types of asystole, that we could save more people. And so, like I said before, this is a bit of an economic decision for your particular hospital.
When
So
you
go ahead, Mark.
Go ahead.
I would say that, how, and this might be too much in the details, but it's what I always think about is, how does so the hospital is going to get their money. How does the ER itself or the ED itself see the revenue? How does that get split up for you guys? Because obviously, for a lot of shots, right, you're asking, your medical director, your nurse director, to invest time and energy into nurses and techs to get extra training, quarterly or whatever trainings to keep everybody's skills up, all these different things, materials, obviously, maybe even getting a circuit that you can keep in your ER. How does it pay out specifically to the ED versus the ICU or the hospital itself?
Great question. Yeah, so the DRG, so this is where you get into the economics of all hospital stays, where the ER oftentimes gets said, oh, you guys don't make us any money, you just are a big sink of money, when in fact, no, we provide the patients so that you can do all these procedures, which are paid in a DRG level later on. And so that same dilemma is going to occur with ECMO. The DRG for ECMO is quite advantageous, more than 100,000. And this was fought a couple of years ago, and it probably will come up again. But the DRG is sufficient to pay for all of their hospitalization, and that should have some, from a hospital administrative standpoint, some resource allocations so that you can provide that DRG to the hospital economically.
Gotcha. So that single DRG is really enough that it should be seen and expenses considered to make sure we're bringing in those patients. And
this is where it does, if you are setting this up, it is worthwhile getting into the weeds as far as the economics with your hospital. Yeah. Saying this is the additional resources we are going to need. This is the additional benefit that you're going to have as a hospital. Let's make this so it is reasonable.
Got it. This has been incredibly enlightening, Zach. To go from something that would be, let's try to save somebody that we've never been able to save before, to mainstreaming a procedure that with training anybody could do. I may be stretching that a bit, considering what an old dog I am and how difficult it is to learn new tricks. But I still can put lines in people. And I think that given the right kinds of hand skills, which I think are teachable to anybody, these are the kinds of things that could be a part of the toolbox of virtually every well-trained board-certified emergency physician. And I personally believe it's a story that needs to be told a little bit more broadly into the community, because it would be pretty exciting to know that you had a shot at survival if one of these catastrophic things happened, because your emergency department and your emergency physicians knew how to do it and had the capability of doing it. I think that would be pretty exciting for a community to know about their facility, their hospital. To me, that would be a great point of pride, a great point of assurance, and it would, in many cases, would be worth a community investment to see this happen. And I think that it would cause emergency physicians to maybe shift a little bit more about how we view ourselves. And what you started out with is, what is the role of emergency physicians? What's the direction in which we're developing? And if we find that this is an area that we can embrace and we can impact, I think that it changes our mindset, and it could change the mindset of our hospital and change the mindset of our communities. And so for all of our listeners and viewers, I hope that this has caused you to really think twice about some of those cases that we always thought we can't do anything with. There's a lot of hand wringing and 15-minute CPR, and you pass on because they're just not responding. They're not going to respond. I can't do this. And the truth is that we have within our grasp the skills and the capability to maybe make a huge difference. So I hope that you have taken a little bit of this, and it maybe inspired you to go talk to the other people in your group, talk to make friends with your thoracic surgeon, make friends with the vice president, the president of the hospital, and say, we've heard about this, and we really think that we should talk more about it. And don't be discouraged if you get, nah, we don't want to do that. Take somebody to reanimate and get them infected with what is actually going on out there. And you might find that you've really changed the course of your hospital, and a lot of patients' lives, and even your profession yourself. So thank you for joining us, Zack. Zack, thank you. We're going to have you back. We're going to have you back to talk more about this and broader applications. And it's pretty exciting. JD came home from Reanimate and said, "You got to talk to this guy. This is pretty crazy." And you have certainly not disappointed. So thank you very much.
You're absolutely welcome. And we've given some data and we've talked about some logistics, but ultimately some of these anecdotal cases, like, they're the ones that change your career. They're the ones that you're like, I can't believe that just happened.
Yeah.
And we have seen in our hospital, we've saved a social worker that works with us every day. We say an OBGYN that we saved, and she ended up going and delivering the patient, the doc that put the cannulas in on her. She just walked by my last shift, and we said hi, and I was just like, she would have been dead. She would have been dead. And now she's back practicing. We have just case after case of these stories that they enlighten your career like you would not believe.
Yeah. Well, thank you. And to all our viewers, I hope you've been inspired to go out and learn more and do more. So JD, thanks for joining us and leading the discussion, and join us again on EP Talk. Thanks.